Well, good morning, and thank you for your hospitality and allowing me to come all the way from Seattle to Auckland. In process, catching an Auckland virus that is now embittering my life, and I hope I can get through the next 20 minutes. But I appreciate this opportunity, and my goal in the next 20 minutes is to convince you that there is science and benefit behind the hands that perform high-performance CPR. Now, I have to do that in 20 minutes, but the good news is that Seattle time, it is now 2:25 p.m. yesterday. So I have 19 hours and 20 minutes, David, to get through this particular presentation, which I'm sure I will need. So let's start off. Let's talk about cardiac arrest, but more than seeing the victim, let's look under the hood, or perhaps, as you would say in New Zealand and Australia, let's look under the bonnet and to ask what's going on in this particular patient in the course of their having a cardiac arrest. And to answer that, we have to really look at what happens in animals. And this is a study that took 10 pigs, and it put those pigs in a cardiac arrest due to ventricular fibrillation and provided no treatment for a period of time up to 40 minutes. So ongoing VF, no intervention, no CPR, no breathing, nothing. And at these time intervals, 1, 2, 3, 4, 5 minutes into the cardiac arrest and all the way out to 40 minutes, the pigs' hearts were biopsied, and they were biopsied for these particular compounds, and the one that I want to have you focus on is called ATP. ATP stands for adenosine triphosphate. It is the high-energy compound that drives every reaction in the body, including the heart, meaning it is the fuel that makes the heart beat. It's the fuel that creates a heart QRS complex, and without ATP, the heart is an organ that can do nothing. And here's what's interesting. If you look at the gas tank of the heart, if you would, as VF is ongoing, look what happens to ATP concentrations in the heart when no CPR is provided. It's a continual diminution. Now, we kind of know something like that probably is happening in the human heart if we happen to look at VF in a patient who got no treatment. Let's say they were being monitored at the time they had VF, they were at home, and this monitor is looked at after the fact, after they've died. Because here's what you typically see. You see VF that has a very coarse waveform, and then it becomes finer and finer and finer. And as you know, in the late stages of VF, it's virtually indistinguishable from asystole. Now, is it possible that what we're seeing on the VF waveform is a surrogate of what's happening inside the heart? Meaning as ATP concentrations and reserve decline in the heart, so does the ability of the heart to create an electrical impulse with the kind of amplitude that says there's vigor in that heart. And as time goes on and ATP diminishes, that vigor electrically gets smaller and smaller and smaller. Now, here's an interesting question. Let's assume a human or an animal is in VF for 10 minutes with no support, and then you shock that individual or that animal. What's the most likely rhythm that you're going to get back? And those of you who are providers know it's either asystole or it's pulseless electrical activity, PEA. Now, why might that be the case using this model? Well, think about it for a minute. Let's assume VF is terminated by the shock. What do you have left to generate contraction? Maybe you don't have enough to generate contraction. All you get is a QRS complex, and that becomes pulseless electrical activity. What if your ATP reserves at that point are so low you can't even generate a QRS complex? What do? You get asystole. So the role of CPR, at least using this model, and this is my hypothesis, is to try to drive those concentrations of ATP back up to a level such that when shock is administered, you not only get a rhythm, you get perfusion as a result of that. And in fact, that was the study's conclusion, saying if you're going to successfully resuscitate from VF, it really takes two ingredients. Number one, you got to have a successful shock. So defibrillators are still an important part of this strategy. But in addition, you need adequate post-shock myocardial function. And I would say that means enough ATP to do something to the heart as a result of what the shock creates. Now, here's the question. Can we turn back the clock by providing CPR? Is there any evidence that says CPR can actually do that? Well, There is, but again, we have to rely on animals, and we're going to need to sacrifice 32 more pigs. Lots of bacon going to be for our lunch hour this afternoon. So here are 32 pigs who are put in VF for 10 minutes with no support, similar to the previous model. And at that point, the pigs are randomized to two groups. One group goes right on to get a shock without any CPR preceding that shock. And the second group gets 3 minutes of CPR, meaning shock is delayed by an additional 3 minutes, and then the shock's administered. And let's look at what the VF waveform looks like in these animals. So here's what VF looks like at 1 minute into VF, so right around here in the animals. And you can see it's very, very coarse ventricular fibrillation. Here's what it looks like at 10 minutes, at the point where the animals are randomized. Can you see how that amplitude has started to diminish, as though ATP has been consumed and that waveform is not as vigorous as before? But look what happens to the animals who get 3 minutes of CPR, and now you look at VF at 13 minutes into the arrest, and can you see that with CPR, something has happened to that VF waveform that's making it look like what it did at 1 minute, as though something was replenished in those hearts during the course of CPR that affected the waveform. Now, the more important thing is what happened then when you shock these animals. Well, in the animals with no CPR at 10 minutes and you shock them, none of them had return to spontaneous circulation. 50% of the animals did if they got preceding CPR. Something about CPR changed the equation and the success of VF defibrillation. So if we talk about CPR, let's just break it down to the two components and say, what are we doing? What are we accomplishing when we administer closed chest CPR? And the answer is that when we compress the chest, realize what we're doing is that we're increasing intrathoracic pressure. And that's not just increasing it in the heart. It's not just the heart that becomes the pump when we do CPR. It's everything in the chest that contains blood. And the lungs, frankly, contain more blood than the heart. And what we're taking advantage of is pushing all that blood through the heart as a conduit and out of the body, out of the chest in order to perfuse the brain and the rest of the body. Which means when we increase intrathoracic pressure, we are ejecting blood from everything that contains blood inside the heart. And the better the compression, the better the forward output, and the better the blood pressure that patient's going to have. Now, decompression. That's where we take our hands off the chest and the chest bounces back or recoils to its original configuration. What happens then? Well, the opposite happens. Intrathoracic pressure, the pressure inside the chest, becomes negative. It's actually a vacuum. It's like a sucking sound in the chest, recoiling back to its full configuration. And what happens at that moment is that the heart and the lungs get refilled. Blood is drawn back into the thorax, filling the lungs, filling the heart, getting ready for the next compression, such that the better the recoil, the stronger the vacuum, the better you refill the chest, and now the pump, when you press on it, has more blood in it in order to create forward output. So the question then becomes, how do we put more bang in the buck in terms of taking full advantage of what closed chest CPR does? And these are the 5 metrics of CPR, high performance CPR, that the American Heart Association recommends. And let's just spend a minute or so on each one of these. First of all, optimize chest compression rate, 100 to 120 compressions per minute. Number 2, sufficient compression depth, at least 50 millimeters or 2 inches if you're US born. Minimize interruptions, meaning keep the chest compression fraction, the percent of time CPR is being done in a patient who's pulseless, at least 80% of the time. 4th, promote full chest recoil. Do not lean on the chest. Let it bounce back to its full recoil position. And finally, control breathing and ventilation. These are the elements that I want to convince you of in just the next few minutes, that if we deploy these basic principles of CPR, the devil in the details, we can improve outcome from cardiac arrest. So let's start off by asking the question, where did we come up with these numbers? 100 to 120 compressions per minute, 50 millimeters. You know, how come these numbers are so magic? And the true revelation is these were an educated guess. These numbers came out based on animal models, on people's opinions, and we guessed saying we think these are the best numbers. But are there any human data that say that's actually the case? Well, for the last 10 years, a group called the Resuscitation Outcomes Consortium, or ROC, which is a North American-wide network created by the Canadian and US government, to perform clinical trials in out-of-hospital cardiac arrest, has accumulated a huge amount of data about the value of CPR. Let's just look at some of that information. Here are about 6,400 adults with out-of-hospital cardiac arrest, all comers, VF, non-VF, in whom during the course of being resuscitated, not only their rhythms and resuscitation were being monitored, but also the rate of chest compressions during CPR. So here's a typical waveform. Here's the rhythm underneath in the patient in cardiac arrest, and here is an impedance waveform that tells you each time chest compressions are being performed. So those numbers were measured, what was the average chest compression rate during resuscitation, and then saying what impact did that rate have on the likelihood of surviving to hospital discharge, a patient walking out of the hospital alive. And here's what was seen. The yellow line is the curve, tells you what happens as chest rate increases, and interestingly enough, between 100 and 120 compressions per minute, we achieve the maximum survival rate in patients with cardiac arrest. Someone once said it's better to be lucky than to be good. We were lucky. We picked a number that makes sense, and now there are clinical data to support it. Now, two observations. Number one, the public in general doesn't press fast enough. That's often the challenge in cardiac arrest. And I think we can say pressing at a rate less than 100 compressions per minute is going to make survival worse. But we as professionals have just the opposite problem. Our problem is we tend to press too fast. And notice the curve of fall off of survival is even worse if you press too fast than if you press too slow. Why do we press too fast? Well, as providers, we get excited. And if we get excited, what happens to our adrenaline levels? They go up. And what happens to the speed that we do things? We do it faster, right? And that becomes a real danger in high-performance CPR. We really need to control our speed. There needs to be a speed limit, which in Seattle-King County we use metronomes in an effort to make sure that providers are not exceeding the speed limit, because you get up to 140, 150 compressions per minute, survival in that patient is going to be worse. Compression rate. What about compression depth? Where's the magic number of 2 inches or 50 millimeters come from? Well, once again, back to rock. 9,000 adults with out-of-hospital cardiac arrest, all rhythms, VF, non-VF, using defibrillators, in this case, that had a puck. And that puck would allow you to measure chest compression depth with each compression. So if you put that as survival to hospital discharge, and you put the depth of compression, and here it is in millimeters, and for those dumb Americans like myself, put it in inches, here is the curve that was generated. And interestingly enough, right at around 2 inches or 50 millimeters, survival appears to peak in terms of the impact of chest compressions. Now, here's where the devil's in the details. Look what happens if you just drop compression depth by ½ an inch, okay? Survival falls by 50%. ½ an inch, 50%. The devil is in the details of the impact of chest compression depth. If I put it in an equation, for every 5 millimeters of depth, you get a 5% bang in terms of outcome. Return of spontaneous circulation improves about 6%, and survival to discharge improves about 4%. You average those together, 5 millimeters is 5%. So I hope I've convinced you that rate and compression depth truly make a difference in cardiac arrest. What about minimizing compression interruptions in CPR, keeping a high chest compression fraction? Here's an interesting illustration of an animal that is in cardiac arrest and has a pressure monitor put in their aorta. That's the golden line here, and a pressure monitor in the right atrium. And here's CPR being administered. And just to emphasize, here's the compression of CPR, where the aortic and right atrial pressure are equal. Here's the decompression phase in between the two, where we're pumping the heart, or where we're creating circulation. Notice that within 3 seconds of pausing CPR, all of those pressures plummet to 0. So by 3 seconds, circulation has ceased in the body everywhere. Now, here's a revelation that I had. I always thought 3 to 4 seconds, no big deal. That's like holding your breath for 3 to 4 seconds and you pick up right where you left off. The problem is when you pause and pressure has fallen to 0 from CPR and you resume CPR, you do not begin where you left off. You go right back to the beginning, and it takes you another 30 compressions or 16 seconds to develop the same momentum of pressure you had before you paused, which means any pause more than 3 or 4 seconds costs you almost 20 additional seconds of poor perfusion. Now, what impact can that have on outcome from cardiac arrest? Here again, data from the Resuscitation Outcomes Consortium. 500 patients in VF looking at the effect of pauses or no pauses on survival to hospital discharge after cardiac arrest. Down here is a clock, and the clock is filled in green as to the proportion of time that CPR was being done in these 500 patients during cardiac arrest, meaning the more interruptions, the less green, and the more white, and the more constant CPR was being performed without interruption, the fuller the green on the clock that you see. And here's what was observed. The better your chest compression fraction, meaning the fewer the interruptions in CPR, the better the outcome from cardiac arrest. So do pauses kill? You can bet pauses kill. And every time we pause CPR, we have to ask ourselves, what's the reason we're doing that? How do we minimize those pauses because they clearly affect outcome? If you want an equation, for every 10% you can increase CPR fraction, you get improvement of survival by about 11%. There's a direct correlation between the two. All right, we've talked about chest compression rate, we've talked about chest compression depth, minimizing interruptions. What about full chest recoil, no leaning on the chest? Well, here again, confession is good for the soul. And here's the problem. CPR is hard work. Compressing on the chest is a huge effort, and we all get tired doing it. And when the compressor gets tired, lifting your hands off the chest is another effort after you just pressed very hard to make it go down, and we tend to lean on the chest, and the patient becomes not just our patient, but they become our table. Now, what happens when we don't let the chest rebound to its full configuration? Let's go back to that decompression phase of CPR. Remember, that's where the chest rebounds and that giant sucking sound inside the chest, the vacuum that's there, is drawing blood back in. If we prevent that from happening, we prevent the heart from refilling because we've compromised that recoil. If anything, we're putting a positive pressure at the time in the chest when it wants to be a negative pressure to suck in that blood. And as a result, we compromise refilling and we compromise output as a result of that. Now, are there data that says that actually happens? Well, back to pigs. We're going to have a lot of bacon today. Here are 9 pigs who were instrumented, and they were put in VF for 6 minutes without any treatment, okay, the typical model. They then got standard CPR for 3 minutes. Now, standard CPR meant 100 compressions per minute, good duty cycle, full depth, and complete recoil, okay? They did that for 3 minutes, and then they did something very interesting. They did the same kind of CPR, but they only let the chest come back to 75% of its full recoil position, meaning they left a lean on the chest. For a pig, that meant 1.2 centimeters of residual lean, not taking the hands off the chest during that period of time. And they asked the question, what impact did they have on blood flow? So here's coronary perfusion pressure. This is pressure that's perfusing the heart and keeping the muscle alive. Here's brain perfusion pressure generated by CPR that's keeping the brain alive. Here's what it looked like when standard CPR was being done. Then remember, for 1 minute, they did the standard CPR with only one modification. They didn't allow the chest to fully recoil. And look what happened to those pressures. Coronary perfusion pressure fell by 1/3. Brain perfusion pressure fell by 50%. And it happened within 1 minute of inadequate chest recoil. A huge price that we pay as a result of that. Number 5, controlled breathing, controlled ventilation. If we take a patient who's in cardiac arrest and we were to put a catheter in their airway to measure the pressure in the chest during CPR and during ventilation, this is what it looks like in an intubated patient with 1 breath every 10 compressions. So here are the chest compressions generating a positive pressure in the chest, right? That's what we're doing with CPR. Here's a breath, 10 compressions, and a breath. So this is what we're trained to perform. Post-intubation, 10 compressions to 1 breath. Interestingly enough, in a US very mature EMS system where they did this, they put a catheter in the airway and measured ventilation rate. Here's what was actually seen in this particular system. And just so that you know what was seen, every one of those is a breath. And even though the providers were trained to do CPR 10 to 1, you almost wonder if they reversed the number and were thinking it's really 1 to 10. And as a result, they were over-breathing patients. Now, why did that happen? The same reason we tend to press too fast when we do compressions. We get excited and we stop thinking and we're pressing fast, and the ventilator can do the same thing. Pressing on that bag, thinking that more oxygen is good. More oxygen is good, but there's a problem. Remember, every positive breath opposes blood return to the heart and chest. And as a result, if we hyperventilate, we're compromising the ability of the heart to refill, in addition to the acid-base abnormalities that we can create when we blow off too much CO2. Now, are there data to say we can kill by hyperventilating patients? Well, back to pigs. 21 pigs, unsupported VF for 6 minutes. They were then randomized. They got CPR, but then they were randomized to either get 12 breaths per minute or 30 breaths per minute, deliberately hyperventilating them. And in a subgroup of the 30 breaths per minute, they supplemented the oxygen with CO2 so you wouldn't get alkalotic. You would basically maintain the CO2. They then did that for 4 minutes and defibrillated the animals. And here's what they saw. Here is the 10 breaths per minute, here's the 30 breaths per minute, here's the 30 breaths per minute with CO2, and this is now just measuring the average pressure inside the chest in those animals during the course of CPR. And as you would expect, if you got more positive breaths, the average pressure in the chest over the course of that resuscitation was significantly higher, and indeed that was exactly what was observed. CPR that had hyperventilation increased pressure inside the chest. Now, what did that do for survival? Survival in the pigs that only got 12 breaths per minute was about 85%. It was less than 10% when you hyperventilated, and CO2 was not the problem. The problem was putting too much positive pressure ventilation inside the chest. So, 5 metrics of high-performance CPR. Compression rate, compression depth, minimizing pauses, no leaning, and controlled breathing and ventilation. Let's ask the question. Those are individual components of CPR. What happens when you integrate in an EMS system an emphasis on high-performance CPR where you try to deploy all of those therapies? What impact can that have on survival from out-of-hospital cardiac arrest? Let me show you data from Seattle, King County. This is bystander witness VF, likelihood of surviving to hospital discharge between 1998 and 2004. And you can see during this period of time, on average, our survival rate from out-of-hospital bystander witness VF was about 33%. We were not happy with that, saying we certainly can do better. And so in 2004, we instituted high-performance CPR, emphasizing some of the same principles we've just emphasized. And in 2005 and 2006, survival went from 33% to 45%, a huge impact in outcome. And some folks said, well, gee, that's just a lucky guess. I mean, this could just be the standard variation in cardiac arrest. And we said, okay, we'll keep monitoring. And those numbers, if anything, only got better. Now, that's VF. What about the asystole and PEA? I mean, that's a substantial proportion of patients that you and I treat in cardiac arrest. Can high-performance CPR change the lives and survival of that group? Well, here once again, Seattle, King County, cardiac arrest from asystole PEA. The purple type lines is the percentage of patients who had return of spontaneous circulation from management in the field. The red bars are those who were discharged alive from the hospital with good CNS function, and the green are those who were alive at 1 year after the cardiac arrest. And you can see these numbers are pretty miserable compared to cardiac arrest, right? I mean, we resuscitate about 26%, only about 3% leave the hospital alive, only about 3% are alive at 1 year. Well, in 2004, we instituted high-performance CPR, the same principles I just showed you, and look what happened to those numbers. Let me just show you what they were. Likelihood of resuscitating successfully increased to 34%, or about 1.5 times higher than it was before high-performance CPR. The likelihood of being discharged alive from the hospital with good neurological function increased from 3 to 5%, about 1.5 times better than it was before high-performance CPR, and 5% of patients were alive at 1 year, nearly twice as many before high-performance CPR was performed. So what's the message? The message is there's science behind high-performance CPR, and if we want to maximize our success in resuscitating from cardiac arrest, all comers, not just VF, asystole, PEA, and we apply these principles, we can save lives, and we can maximize our impact as providers and the life and livelihood of patients as a result. So, 5 metrics: optimize rate, optimize depth, minimize interruptions, promote full chest recoil, control breathing and ventilation. If you have 2 hands, you qualify. Everyone in this room has the capability of doing this and saving lives. Thanks for your attention.